From San Francisco, it's Grumpy Old Doc with Dr. Gene Bede.
Hello, this is Dr. Gene Bede, and welcome to the Grumpy Old Doc. I think when I was a young doc, I learned what a lot of doctors do, and that is kind of bite your tongue in social situations. You don't want to give medical advice to somebody who's not your patient. It's unprofessional. And you don't know all of the information. You're not the patient's doctor. It may be inappropriate as well. And yet sometimes it's difficult. Because I hear people gripe about our healthcare system, and they gripe about things that appear to be misguided to me, such as they couldn't get an antibiotic for their sinus infection, or they waited too long in the emergency room when they had the flu, or their back has really hurt for several days now, and they want a referral to a back specialist, and they seem unable to get it. I'm going to come back to all of these examples, but there are some things I never hear people talk about. I never hear anybody say, geez, I'm not getting enough colonoscopies, vaccinations, my diabetes is out of control, and I don't hear any of these complaints ever. And sometimes it really worries me. The issue is what I call the Goldilocks theory of medicine. You don't want too much, you don't want too little. You want the right amount of medical care. You can have too much of a good thing, and modern medicine is without a doubt a good thing. We look younger, we're living healthier, we're living longer, in large part because of advances in modern medical care. But you can get too much of a good thing. I made a reference in an earlier show about how my wife and I made sure we got out of the hospital as quickly as we could after our children were born, even though the insurance company by law was required to cover another day or so in the hospital. We wanted out. We knew if we stayed in the hospital too long, the odds of something like an infection or some other disaster climb radically. The hospital's full of sick people. It's not a safe place to be. Similarly, I see friends that get surgery after surgery, and each surgery is very safe, but perhaps they go to surgery, for instance, for musculoskeletal complaints a little earlier than I would. Maybe that's harmless, but you know, if you roll the dice often enough, it will come up snake eyes on occasion. And I can think friends of mine who've had multiple joint replacement surgeries, sometimes for a really bad joint initially, and things go so well, they say, well, this other one hasn't been giving me too much problems, but I might as well get taken care of. Sort of like putting a new radiator in your car. And then they come away with some sort of complication that could have been avoided entirely, perhaps, if they had waited until when the surgery was truly indicated. So why do we have this disconnect where people feel they're not getting enough health care when in reality maybe they want too much, and people almost never estimate that they're getting too much health care? I think it goes back to the way our insurance system is built and the scientific basis of medicine. Right now, we have a very scientifically complex discipline. There's a reason why people go to school for all those years: university, medical school, internship, residency, fellowship. It's because this stuff is really complex. There's some very complex science involved here, and a lot of things that have not yet been answered scientifically. They can only be approached on the basis of experience and hearing from people who've had experience. Without that experience, it's very easy to convince yourself that you have this, that, the other condition, and that this, that, or the other drug is the one that's right for you. And I only have to think back to the common experience that many doctors had as medical students. For the first time, we would read about these rare and exotic diseases, and we would all immediately develop their symptoms right afterwards. And we would head to the pharmacology book to look for what the cure was. And if there was any sort of treatment mentioned, there would be people seriously considering how to get it for themselves, all without a whit of evidence that they had the underlying condition. A little bit of knowledge can be a dangerous thing. Before World War II, We had very little science in medicine. Doctors didn't have penicillin, cardiac catheterizations, open heart. What they had is they held your hand while you died. More than scientists, they were healers. They were folks that dealt with illness even though they had little to offer, in many cases, over the natural healing process. The other piece of this issue is how healthcare is paid for. It's paid with somebody else's money. And to paraphrase the late, great Steve Goodman, spending somebody else's money doesn't make you lose any sleep at all at night. Again, this happened right around World War II, what sociologists would call a dual inflection point. Two things changed simultaneously in healthcare. One is the science, and the other one is the status of insurance. Insurance before World War II was a rare thing and was generally put in place to help people suffering from the economic effects of the Depression, whether it be rural communities, rural hospitals, but certainly not the kind of prevalent insurance available through your work that we take for granted today. Despite everything else in healthcare reform, most of us take for granted that if we have a good job, there will be healthcare benefit. As recently as World War II, that was not true. Let me give you a couple of vignettes. As World War II broke out, penicillin, the new wonder drug, was clearly something that had great value. And yet, at the time, it was so scarce, it was estimated at one point there wasn't enough penicillin in the entire nation to treat a single case of meningitis, and protocol at hospitals routinely called for anybody getting IV penicillin to have a catheter placed in their bladder. Why? So their urine could be recovered, and the penicillin could be extracted from it, and it could be reinfused into people's bodies. Fast forward 10 years, 1950s, Michael Millinson tells us in his book, Demanding Medical Excellence, that doctors are treating more than half of all patients that visit them with penicillin. And this ostensibly includes folks that don't have infectious disease, folks, because there's no way 60% of the people that visit the doctor have infectious diseases. People are using penicillin for neurologic, cardiac, orthopedic, all sorts of events where it wasn't indicated. And that's the beginning of why penicillin pretty much doesn't work for anything anymore except strep throat and some forms of pneumonia. At the same time, facing inflation, facing a labor shortage during World War II, the War Labor Board allowed employers who were restricted by wage controls for offering more money during the war to the scarce remaining labor force, that they could offer health care benefits, because the reasoning was health care benefits could never rise to more than 5% of total compensation, and they could not respond in any way that would contribute to inflation. So almost nobody had health insurance before World War II. By 1960, most people in this country who worked had health insurance through their employer. So today we have extremely complex decisions that sometimes are being driven by direct-to-consumer advertising on TV, sometimes by misinformation about what's appropriate in health care. And we have insurance that since the 1960s has only expanded with Medicare, Medicaid, prescription drug coverage, and increasingly, no matter how obscenely these products are priced, somebody else is paying for most or all of it. The insurance company, my employer, Medicare, Medicaid. What did people do before insurance? Most doctors in this country practice medicine according to what was called the sliding scale. What did that mean? Rich people got charged a hefty amount. Poor people may have gotten their care for free. People in the middle paid more or less depending upon their wealth. Maybe you got a chicken from a farmer. Maybe you got a $100 check from somebody who had a good job in the city. This sounds suspiciously like to each according to need, from each according to ability. Most of my fellow doctors are outraged when I suggest they practiced almost perfect Marxism before World War II in the way they charged for their services. Obviously, that's pretty much gone today. Maybe someday I'll do a show of what our healthcare system would look like if we brought back the sliding scale. Maybe that we will not have a solution to all of our problems until we bring back a 21st century analog. So let's go through the 3 examples that I suggested. 1, antibiotics. I hear people complain all the time. I went to my doctor, I couldn't get antibiotics. I applaud that doctor. I almost never see anybody who got sick because they didn't get antibiotics in a timely fashion. I see far more cases of people who get antibiotics that didn't need them and get some side effect from them, mostly minor. My kid had an ear infection. There was fluid behind his ear. The doctor didn't give him antibiotics. I had to go to the emergency room to get antibiotics. Ear infections are one of those things where thinking has changed. A couple things. 1, the less experienced the doctor is at seeing children, the more ear infections he'll diagnose. An ER doc who is not comfortable with seeing children is much more likely to diagnose an ear infection than a pediatrician who's seen many, many, many thousands of ear infections over his career. Child doesn't have a fever, older child, no pus coming out of the ear. Really, the thing is pain control, and antibiotics only if those things develop. How many antibiotics are sprinkled over our kids for ear infections? And the general story that I see is somebody has a cold. They tug at their ear. Somebody looks into the ear, looks at mom, realizes this is a parent who wants an antibiotic. They look in the ear. They see something that's highly questionable. Maybe they don't even see the eardrum. I've seen kids with such impacted wax that have been diagnosed the day before with an ear infection. It's ridiculous. They go, thank God there's an ear infection. I can give this child some antibiotics and mom will be out of here happy. I don't think there's a primary care doctor in the country who hasn't felt pressure to prescribe antibiotics unnecessarily. Let me give you some other examples where they're used unnecessarily. Sinus infection is my favorite. People said the snot has turned green. Thank God my doctor called in an antibiotic. Well, guess what, folks? Almost everybody's snot turns green the last few days of a cold. What that is, it's all the cells that line your nose and everything that was infected by that virus and all the white blood cells that died battling it, all the tissue back there, the upper layers of your throat and nose that have died and are now coming out. It's your body flushing the garbage out of your nose, folks. Green snot does not mean you have a sinus infection. Having a positive sinus x-ray does not mean you have a sinus infection. A cold will obliterate your sinuses on an x-ray just as much as a bacterial sinus infection that demands good antibiotic. Whether you have a sinus infection that should be treated with antibiotics is not an easy thing to determine. And it's not a common thing either. Most sinus infections that are treated with antibiotics are not sinus infections. They're the tail end of a cold. Same thing is true of bronchitis. People say they have bronchitis. They have a viral infection. Maybe even they have walking pneumonia, but it may be a viral pneumonia, and antibiotics will be of no use. Now, I'm not giving individual advice to people. There's obviously a lot of challenges here. You don't have a spleen, antibiotics are really important for you. You have chronic obstructive pulmonary disease, and you have a exacerbation. Maybe your tune-up includes a little antibiotics. Tonsillitis. Wonderful thing to treat with antibiotics when somebody has strep. They don't get rheumatic fever. Even though there's some debate about it, in my experience, kids get better more quickly when they get good antibiotics. But that's only for strep tonsillitis, which is probably a small percentage of all tonsillitis. Most tonsillitis is not helped by antibiotics. You have to do a throat swab to detect strep. If your doctor just looks at your throat and gives you antibiotics, there's a good chance you didn't need them. So what's the harm of getting a few antibiotics sprinkled here and there that you don't need? Well, a lot of folks would say there's very little harm. Probably the people who raise livestock would say that because they just routinely sprinkle antibiotics over their feed to keep them from getting sick from the garbage that they're feeding the livestock, and because they're so close together, and because it makes them grow better. Kids in this country are bigger than they ever were before. Maybe we should just serve them Amoxiflakes in the morning, some nice sweetened cereal that's coated with antibiotics. I'm being facetious, folks. These drugs are very safe, and most people get away with taking them their whole life.